Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Welcome to the deep dive. Today, we're focusing on a procedure that is, truly foundational to systematic surgical practice, the open appendicectomy.
It is. And while laparoscopy has really taken center stage, the reality is that the open technique remains absolutely vital. I mean, it's the necessary approach for complicated cases.
Like gangrenous or perforated appendices?
Exactly. Or in resource-limited settings where the equipment just isn't available. Sometimes it's also about specific patient factors, say a hostile abdomen from previous surgeries, that mandate a traditional approach.
Right. So for those of you in training or maybe just refining your foundational skills, mastery of this open procedure it's just non-negotiable. We've synthesized a comprehensive guide today.
And our mission really is to distill the core steps, the critical decision points, and some of the often missed technical nuances that can transform a basic operation into a meticulously performed one.
This isn't just a checklist.
No, not at all. We're focusing on the how and, maybe more importantly, the why. Why certain techniques like muscle splitting versus cutting or simple ligation versus inversion have shifted over time based on evidence. This is about building systematic mastery from the ground up.
Before we jump into the technical details, a critical note for all our listeners. This content is for reference and educational purposes only. Please, always adhere strictly to your local clinical protocols and institutional guidelines in your practice.
Absolutely.
Okay, so let's begin at the very start. Pre-operative preparation. What are the absolute must-dos before we even get to the table?
It all begins with systemic support. Nil by mouth status is standard, obviously, but aggressive intravenous fluid resuscitation is often critical.
Especially if the patient is dehydrated or septic.
Exactly. And of course, broad-spectrum prophylactic antibiotics initiated promptly.
So we've positioned the patient supine, usually under general anesthesia. But there's a step that should happen after induction once the muscles are relaxed that I think a lot of trainees overlook.
Oh, this is absolutely essential. After the induction of anesthesia, the surgeon must palpate the abdomen again.
Why is that so important?
Because once that rigidity and guarding are gone, you can often confirm the exact site of maximal tenderness or, clearly feel a subtle palpable mass you couldn't before. This final check is what directs your incision placement most accurately.
So it reduces the need for extending the wound later on.
Precisely. Guiding the cut brings us to that anatomical landmark everyone knows, McBurney's point.
That classic spot, 2/3 of the distance from the umbilicus to the anterior superior iliac spine. But the real debate isn't where to cut, it's how you cut. We have the oblique gridiron incision versus the transverse lans.
This is a crucial early decision. The older gridiron, or McBurney incision, it runs obliquely following the external oblique aponeurosis fibers. The lans incision, on the other hand, is transverse.
At the same point, just oriented differently.
Exactly. It's at the same approximate level, but it's oriented along Langer's lines, the natural skin creases.
So why the modern preference for the lens? What's the real advantage?
Well, trainees need to understand the functional difference here. The lens offers vastly superior cosmetic results, that's the obvious one, but more critically, it often gives you better access to the appendix base.
Especially for those tricky pelvic appendices.
Yes. And it allows for easier transverse extension if you need more exposure. The gridiron, while it's quick to make, can sometimes lead to muscle fiber retraction that actually limits your visualization if the appendix is tucked away deep.
Okay, so we're talking an incision of about 3 to 8 centimeters. We get meticulous hemostasis, watching out for the superficial epigastric artery branches. And then we start the journey through the abdominal wall.
Indeed. And this is where anatomical precision really prevents major complications. We identify and incise the external oblique aponeurosis following its fibers. But here is the critical principle.
Don't cut the muscle.
Never cut the muscle. The underlying internal oblique and transversus abdominis must be split bluntly. They are spread, not cut, to protect the motor innervation of the abdominal wall.
It sounds so straightforward in a textbook. But if you're operating through a small incision on a patient with thick muscles, how do you maintain that blunt split without just tearing things? What's the biggest mistake you see?
The biggest mistake is being too aggressive. You're not trying to rip the fibers apart. You're gently spreading them along their natural orientation. Use artery forceps or even your finger and just gradually widen the opening.
And if you cut them?
If you cut those fibers transversely, you risk denervating that segment of the abdominal wall. That directly contributes to long-term incisional hernias and post-op pain, A good outcome really starts here.
So once we're past the muscle, we hit the transverse fascia and then the peritoneum.
And at the peritoneum, safety is just paramount. You have to elevate that layer with 2 artery forceps, create a little tent, and make absolutely certain no bowel is grasped before you make a small, controlled stab incision.
Okay, and what if we open it and immediately find contamination?
That's a critical moment. If you see purulent or turbid fluid, that's a sign of complicated appendicitis. You must immediately collect a sample on a swab.
For culture and sensitivity.
Yes, send it urgently. That result is going to dictate your post-operative antibiotic regimen. Don't skip that step.
Now for the classic hunt, locating the appendix. It's famous for its variability. What's our ultimate reliable anatomical GPS in there?
Your landmark is always the cecum. Always. You look for the Trainee coli.
The 3 muscle bands.
Right, those 3 distinct longitudinal muscle bands in the large bowel. They reliably converge at one single point, the base of the appendix. Following the anterior Trainee coli is usually the quickest way to guide yourself straight there.
Even if the appendix is totally buried in inflammation.
But even then. But the location is, as you said, highly variable. Retrocecal is most common, maybe 45%. Then pelvic. So if we encounter a deep retrocecal appendix, how do we mobilize it safely?
Right, it's totally obscured by adhesions.
First, you have to gently, bluntly break down any inflammatory adhesions. For that deep retrocecal position, you need adequate exposure. That often means you have to perform a formal mobilization of the right colon.
And that involves dividing the lateral peritoneal reflection,
which is known as White's line of Tolt.
Walk us through that maneuver. What are the major risks there? Why is it so critical to get that right?
You have to be in the correct vascular plane to mobilize the cecum medially. This gives you the access you need. The major risk, especially for trainees, is wandering too deep retroperitoneally.
And that's where the ureter lives.
That is exactly where the right ureter lies. An injury there is a devastating complication, so dissection has to remain superficial, close to the colonic wall.
Once we have the appendix exposed and mobilized, handling it is key, right? Especially if the tissue is friable and inflamed.
You handle it with respect. Use non-crushing instruments like Babcock or Lane's tissue forceps. You need a grip that's firm enough to hold traction without tearing through the wall, then you deliver it gently into the wound.
Okay, we transition now to vascular control. We have to divide the mesoappendix, which contains the appendicular artery.
This is a cornerstone of preventing hemorrhage. The appendicular artery is usually a branch of the ileocolic artery, and that whole pedicle has to be secured meticulously before you amputate.
So how systematic should a trainee be here?
Very. We use serial clamping, cutting, and ligating the mesoappendix, working from the tip down towards the base. Use absorbable suture, like Vicryl or chromic catgut. The goal is double insurance. Make sure the main trunk of the artery is clamped and securely tied off.
No mass ligation.
Never rely on mass ligation. Secure individual pedicles.
Yeah.
That's how you guarantee hemostasis.
Which brings us to the famous stump management debate. The final critical decision. We've got the classic inversion versus the more modern simple ligation.
Right. And historically, for decades, the standard procedure was to place a seromuscular purse string suture around the caecal base, and then you'd invert the stump after amputation.
And the rationale for that was?
The theory was simple. Seal the cut surface away from the peritoneal cavity to prevent any bacterial leak and, subsequent abscess formation.
It sounds logical, but it definitely adds complexity and time. So what drove the shift toward just simple ligation?
The evidence. Contemporary studies just demonstrated that the theoretical benefit of inversion, it didn't translate into a statistically significant reduction in complications.
So no real difference in abscess or leak rates?
Exactly. And in fact, inversion itself carries some minor risks, like causing a bit of localized caecal narrowing.
So the deep dive nugget here is that simple practicality, supported by evidence, won out.
Precisely. The modern standard is simple ligation. You crush the appendix base, place a secure ligature around that crushed mark, and then amputate about ½ centimeter distal to it. It is faster, it is technically easier, and it is just as safe as inversion. It's the preferred method now.
Once the appendix is out, we move to the peritoneal toilet. Critical in any case, but essential if there was gross contamination.
And it must be thorough. We use copious amounts of warm normal saline, sometimes dilute betadine, to perform lavage. You have to wash out the right iliac fossa, the pericolic gutter, and then aspirate completely.
Irrigation and then aspiration.
Yes, you can't just suck out the free fluid. You have to irrigate to mobilize the contamination and then get all of that fluid out to prevent an abscess.
after cleansing the field, we also need to survey the neighboring structures, right?
It's a non-negotiable post-removal inspection. Always look at the terminal ileum. Are you seeing signs of Crohn's disease that might be mimicking appendicitis? And in female patients, always inspect the right ovary and fallopian tube to rule out gynecological pathology.
Good point. What about drains? When do we use them and when do we avoid them?
They're not routine in uncomplicated cases. A drain can be a foreign body and a source of infection itself. However, if you had significant unmanageable contamination or a contained abscess, then a closed suction drain is warranted to prevent a collection from reforming.
Let's talk closure. This is a vital decision point because the risk of surgical site infection is highest here. How does contamination dictate our closure strategy?
Contamination changes everything. We always close in layers to restore integrity peritoneum, then the muscle layers. But the skin and subcutaneous layer require the most strategic thinking.
So give us the 3 main strategies based on how dirty the field was.
Okay. 1, for uncomplicated cases, primary closure is ideal. Subcuticular absorbable sutures give the best cosmesis. 2, for moderately contaminated cases, you might close the deep layers but intentionally leave the subcutaneous tissue and skin open, packed loosely to let it drain.
And number 3.
3, for grossly contaminated or perforated cases, delayed primary closure is often the safest choice. You close the deep layers, leave the wound open for a few days for daily cleansing, and then suture the skin closed once it looks clean and healthy.
It's a necessary evil to prevent a deep infection. Okay, a quick snapshot of the patient journey post-op.
There'll be NPO initially, with continued IV fluids and good pain control. Early mobilization is absolutely essential to prevent ileus and DVT. For a simple case, we'd expect discharge in 2 to 3 days.
We know complications are a reality. Beyond SI and abscesses, what are the red flags we need to reinforce for trainees in that first week post-op?
Look for a persistent fever, an unresolving ileus, or an unexpected return of pain. These are the big signals for an intra-abdominal abscess. And never forget the risk of an incisional hernia down the line, especially if that muscle-splitting technique wasn't done well.
To wrap up our technical session, what are the final non-negotiable takeaways?
Number 1, always verify the entire appendix was removed to prevent stump appendicitis. 2, always prioritize nerve and muscle integrity during your dissection. And 3, critically, if you're attempting a laparoscopic case and run into technical difficulties.
Like dense adhesions or bleeding you can't control?
Exactly. A prudent early conversion to this systematic open technique is a sign of good surgical judgment, not a sign of failure.
So we've navigated the entire systematic process of the open appendicectomy, from incision strategy all the way to the latest evidence on stump management. Mastery of this procedure really provides a critical template for technique and crisis management.
And what's truly fascinating here is how the core steps of McBurney's operation from over a century ago are still sound. Yet these smaller details, like the choice between simple ligation and inversion, they continue to evolve based on rigorous clinical evidence. It's all about efficiency without sacrificing safety.
It's a perfect example of evidence-based practice.
It is, and it raises an important question for you, the listener, in which other common fundamental surgical procedures are simple, time-tested steps currently being reevaluated for efficiency and, equivalent long-term safety.
A great thought to mull over. And a reminder, of course, that this knowledge is for reference only. Please ensure all your clinical practice adheres strictly to your institutional and local guidelines.
And if you found this deep dive valuable for your practice or your training, please share it with at least one of your colleagues or friends to spread this essential knowledge.
Also, be sure to check out our YouTube and other social media pages for more in-depth content and discussions. We appreciate you joining us for this deep dive.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.